So welcome, everyone. We're so glad to have you join us tonight for our chronic pain roundtable. We have a great group of physicians here with us tonight. And we're thrilled to be hosting this event. It's a part of a three-part series, which we hope is a conversational series. You know, we intentionally scheduled this for March to coincide with Women's History Month. You know, it's a time to celebrate women who share their knowledge, their experience to benefit others. And that's exactly what we hope happens tonight during our discussions. Women play so many different roles: mother, wife, patient, caregiver, employee, employer. And the pandemic has really intensified the challenges for so many of us as we navigate through these roles. So it's more important than ever that we help each other take control of our lives, and particularly those who are suffering with chronic pain. We have an accomplished panel of speakers who are going to help us do just that today. I want to thank each of them for sharing their expertise, their insights with our community and supporting the work of the Arthritis Foundation. But before I get started, before we introduce our speakers, I wanted to just mention a few things, give you a few updates. As I mentioned, this is part of a three-part series. So our second event is on March 18th, and we'll hold a Facebook Live event titled Real Talk about chronic pain and daily living. And we'll have our speaker, our facilitator will be Bonnie Simpson. She's a retired orthopedic surgeon and herself an RA patient. And she'll moderate a diverse panel of members of our community, people with arthritis, who'll be sharing tips and strategies from a patient point of view. So we hope you can join us for that as well. And our third event in the series will be Men with chronic arthritis pain, overcoming the stigma, finding solutions. And that'll be on June 17th, and we've scheduled that during Men's Health Week. I also wanted to mention a new program that I'm excited will be launching on pain, and we want you to look forward to participating with us. It's an opportunity for people to set personal goals around pain. You know, things like, I want to be able to sleep for 6 hours, or I want to be able to walk a mile, or I want to be able to walk around the block, whatever that personal goal might be. And we'll have a native app with tools that you need to achieve your goals, track your progress, and there'll be support from the Arthritis Foundation and the opportunity to join with our community, others like yourself, and have that support. You'll be able to monitor your mood, your pain level, your sleep, physical function, all the things that are related to pain as a chronic condition. It'll offer you opportunities to make sure you stay on your medication. And it'll be a single source tool that celebrates progress, big and small, and empowers you to take control of your pain. We're really excited about this new initiative that will be launching in May, and I want you to look forward to seeing more about that. But now it's time to get started for the main event, and I have the distinct pleasure of introducing Dr. Natalie Azar, a good friend to the Arthritis Foundation, a rheumatologist at New York Langone Medical Center, and a clinical assistant professor at the Department of Medicine at NYU Grossman School of Medicine, where she treats all types of inflammatory arthritis, as well as fibromyalgia. As you probably know, she's also an NBC News Medical Contributor, and we're delighted to have her as our facilitator tonight. So Natalie, I'm going to turn it over to you. Thank you.
Thank you so much, Anne. It is definitely an honor and a pleasure to be back with the Arthritis Foundation tonight. And before I get started introducing the panelists, just a little bit of housekeeping that we wanted you guys all to know. We received over 600 questions from all of you about tonight's topic, pain in women in arthritis. And so unfortunately, we won't be able to get to all of them. We tried to embed some of the topics into the conversation, and we will have time at the end for a little bit of a Q&A, and hopefully we can get most of your concerns addressed. And the other thing I wanted to mention, or we wanted you guys to know, is that next week, there will also be a COVID webinar on the COVID vaccine in terms of safety and efficacy, and whether or not you as a patient with arthritis or autoimmune disease on immunosuppressive medications are a candidate for the vaccines, and everything you need to know, which I know is just top of mind for everyone. So you can sign up for that at arthritis.org/webinar. Okay, so now on to our panelists, the experts for tonight. I'm super excited to introduce you all to them. Our first is Dr. Elaine Husni. She is the Vice Chair of Rheumatology and the Director of the Arthritis and Musculoskeletal Center at the Cleveland Clinic. Dr. Husni's research interests include health outcomes of patients with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and osteoarthritis. Next is Dr. Natalie Dattilo. She is a clinical health psychologist and director of psychology services at Brigham and Women's Hospital. She uses an individualized and evidence-based approach to treatment and specializes in mood, anxiety, and adjustment disorders, stress psychology, women's issues, and coping with chronic medical conditions. And last but not least, Dr. Rinelda Horton, who is an orthopedic surgeon with Kaiser Permanente Mid-Atlantic Medical Group in the Washington metropolitan area. She's been with the Permanente Group for over 16 years, and prior to that, she was in private practice in North Carolina for 10 years, specializing in joint replacement surgery. So this is one of those times where I'm so happy we can do this on Zoom, but it would be even better if we were all together in person, because I think the first thing I would ask our audience is, with a show of hands, how many of you have experienced pain because of your rheumatic disease? And then I would also ask how many of you who said yes to I've experienced pain felt that maybe your practitioner didn't really quite listen to you or hear you so well. And if I delved even further, I would ask especially our participants of color if they felt even especially perhaps not listened to or neglected, which, as we know, tends to be the case. And I'm going to start, before we get into, the physiology of pain and rheumatic disease, I'll start with a very, very, very short anecdote. And that was roughly, I would say maybe 10, more than that, maybe 13, 14 years ago. I remember I just had my son. So actually it was probably 15 years ago, 16 years ago, when I had a rheumatoid arthritis patient who I've been following for many, many years and had her on multiple different biologics, but finally got her disease under control. And she came to see me one day and she said, no, I hurt, I have pain everywhere. And I examined her, no synovitis, no inflammation in her joints. And I said, I don't know what's going on. I don't know what's going on. And why did I feel that way? Or why was that the case? Well, because up until that point, the teaching had basically been, you either have rheumatoid arthritis or you have fibromyalgia. They are diagnoses they are not mutually exclusive. You have to pick one or the other. We would give a therapeutic or diagnostic trial of steroid to try to distinguish between the two. And then lo and behold, the light bulb went off and we all realized en masse that patients with osteoarthritis and lupus and rheumatoid arthritis also can acquire this secondary pain syndrome, this neuropathic pain of fibromyalgia. So with that, as sort of a starting point, I'm gonna sort of throw the first topic or question to Dr. Husni to talk about, how we evaluate our patients when they come in complaining of pain. How do we distinguish between inflammatory RA pain versus degenerative OA pain versus neuropathic pain and fibromyalgia? Just if you could just give us a little bit of your opening thoughts on that whole topic, Elaine.
So I'm just so happy to be here, that we're even talking about pain, right? So a lot of times we kind of brush it under the rug and maybe, address it next time. But it's really great because I think this tells us that this is an important vital sign, like the fifth vital sign, and that we can start exploring how to think about pain. And unfortunately, there's no one question. Natalie asked a great distinguishing question. Is there a way that I can just tell when you walk in the door, what's your trigger of your pain? And the answer was no, we can't ask with one question. We really need to get to know you, how pain is impacting your life, how well your underlying disease burden is being, treated. So there's a lot of things that kind of go into the pain. I feel like pain comes in many different flavors. So, unfortunately, there is no one, sort of question, but I love the fact that we're talking about it openly. We're not trying to hide it or sweep it or say it doesn't matter and we just need to look at your disease only.
Thank you so much, Elaine. Rinelda, perhaps you can give us a little bit from your perspective. If you have a patient who comes in and complains of knee pain, but then you start asking some other questions and lo and behold, they don't just have joint pain, they have muscle pain, they start complaining of fatigue. Are you seeing that in your practice? And what do you use as sort of your rate limiting symptom or complaint to refer to a rheumatologist?
That's a good question. It happens a lot. And I always think that the pain a lot of times is multifactorial. There's several things that's causing the pain. Sometimes it's an activity they've done before that may have triggered it. Sometimes if they're complaining of pain in multiple areas, that's when I think more about the rheumatologist, referring them. They'll usually get some markers, inflammatory markers, do some lab work. But the main thing is just spending the time and getting a good history and, talking to the patient, giving them time to tell me what's going on and then trying to decipher, pull it all together.
That's great. And I also remember, I thought someone was going to say something. I remember another one of those light bulb moments was the realization that we would have our patients go for a knee replacement, Rinelda, and they would complain of persistent pain afterwards, right? And we would always send them back to the orthopedist, make sure that the prosthesis was in place, there was no loosening, there's no infection, and no, everything is okay. So why do they still have pain? And now we understand that, the brain has mapped that area out as painful, which is why a medicine like Cymbalta or something like that is often used in patients and why it has an approved indication for chronic pain independent of depression, anxiety, or fibromyalgia.
And in addition to that, I always tell patients too that though a knee replacement is an excellent operation, it's not 100%. It's never going to give you the knee that you had when you were 20. So I think we have to have realistic expectations. And then we all have patients who have perfect x-rays. All their labs are normal. It's not infected, but they still hurt. And we can't find a reason for it. We've sent them to colleagues for a second opinion. And we all have those patients. So I try to explain that to my patients before surgery. And then again, afterwards, if we were to get those patients, then I ask them, well, do you think you're any better than you were before surgery? And most of them will say, well, yeah, I'm better than before surgery, but it may not be perfect. I mean, we all wish we had those patients where everyone was perfect, had no pain, but it's reasonable, particularly when there's pain coming from other sources, back, hip, other things that they may still have some pain and it may not be the way they were when they were, say, 20, like I try to inform them of that.
I am so happy that you said that because I actually don't say that to my patients before surgery, but I think that that's a good thing to do, right? Because you're setting a very realistic expectation. I mean, unless they've had a complication, I would say most of my patients are happy when they have had, some sort of arthroplasty, right? I mean, you're going from a very diseased joint to a new joint, but to sort of say, look, you may not have your 25-year-old knee. I think probably that's my pearl for the night. Thank you, Rinelda.
Right. I've used that for a long time. And actually I tell patients, part of my pre-op assessment, which is the appointment that I spend the most time with, because I think it's very important to go through everything with the patient, not to frighten them, just so they understand. And I tell patients that, you could have these complications, hopefully you won't, but I want you to understand and I want to spend the time to explain them to you so that we can work through this, together. But
Right.
One of the things I tell them, I said, most people still have pain after their knee replacement. Most people say it's not every day, and on a scale of 1 to 10, it's a 1 or a 2. And most people say, and I always say, I quote them, they say it's better than it was before the operation.
Right.
So it's just having a realistic expectation beforehand. And I think that really helps with your outcome, your expectation.
I agree. Natalie, if I could ask you, because, of course, the vicious cycle of pain, contributing to depression, depression exacerbating the perception of pain, and that whole cycle. What have you seen in your practice, and what kind of guidance do you offer patients, either pharmacologic or non-pharmacologic, in terms of how they deal with their chronic pain?
It's such a great question. It's such an important question. I also wanted to say I'm so honored to be on this panel, to have this such an important conversation, and to think about women in pain, and to address some of these really important questions, especially as it relates to the psychological experience of pain. Pain is sort of a whole person experience. And what we know is that how you think about pain affects how you feel it. How you feel pain affects your experience of the pain, and that you can train yourself to think differently about the pain, and that has positive outcomes on how you experience the pain, and how intense and frequent your flare-ups are.
Which I find fascinating, and for two reasons really, because on the one hand, there are certain conditions, let's say chronic fatigue syndrome, where cognitive behavioral therapy is not only not necessarily recommended, but there's always that concern that that minimizes someone's complaints if you're telling them to sort of deal with it, right? As opposed to fixing it. But the literature, especially for something like fibromyalgia, is that being able to not catastrophize the pain, right? To sort of be better able to understand, this is what I have, this is what I'm experiencing, really actually helps with their pain, which I think is really, really important. And it's not saying we don't believe you, you need to learn how to deal with your pain better, but actually learning how to deal with the chronic pain does help. Is that what your work
There are
really
different
shows? Or
absolutely. It's how you think about it and how you approach it that can make a big difference in your experience of it. And so one of the other techniques, in addition to cognitive behavior therapy, is acceptance and commitment therapy that has been shown to be really effective for also managing pain conditions. And it involves really coming to a place where you're willing to have the pain condition simply because it's there, and at this point it's not going anywhere, and live a valued life that's full and satisfying alongside it, that it doesn't have to get in the way or be a barrier to the other things that you want to do in your life, that it doesn't have to impact so significantly the quality of your life. But the difficulty is getting to that place where you're willing to say, okay, I have this, it's going to be with me, now what? And a lot of people misinterpret that as like a resignation or a giving up, or I guess it doesn't matter what I do. And it's a much different process than that. It's an active choosing and a willing to have this be the case for now, because it is, and still live a full life alongside that.
Wonderful. So as an adjunct to that, of course, we, Elaine, you and I are having to treat our patients' pain. So if we, we'll set aside our biologic and DMARD therapies, which who would have ever thought that was going to be the easy thing to treat, right? And I'm sure we've had this conversation with patients where I can say, well, there's good news and bad news. You don't really want to have RA, but if you had RA, I would give you this laundry list of medications with an equally long list of potential side effects, but you're going to feel great, right? And then we have, chronic osteoarthritis pain and chronic neuropathic pain. Can you talk to us a little bit about how you approach the treatment of, non-inflammatory, non-RA pain? And I'm sure everyone's a little bit different. So tell us, how you go about it.
Yeah, so I think, patients definitely, as the panelists have alluded, we really have to try to empower people with pain and for them to actually open up and talk to us about pain, because as a physician, we have biases too as we enter, into the room, whether a patient's lifestyle habits, whether or not they're compliant with their medication, for their underlying disease. So I think what's really helpful to me is to really understand their triggers of pain. So Natalie, you and I are rheumatologists, so we probably treat pain that is more associated with, movement and stuff, right? Because we're always doing joint counts and we're, really concerned about joints and we're coming from that perspective.
Mm-hmm.
Well, I could see Natalie is really, you're probably a lot better at really understanding centralized pain and, other sensitizations that we see with the type of pain that may not get better with just, the underlying disease burden, sort of protection and treatment. And I find that very, very challenging. Because people can have different triggers of their pain, right? It could be from osteoarthritis or rheumatoid arthritis or whatever arthritis they have. But in addition, they can also have a central sensitization type pain, which is actually separate, as you had, sort of alluded to, Natalie, and both Natalies actually have dealt with, another different type of pain that I think we're not probably as good as. And I think sometimes fibromyalgia has a really kind of negative connotation to it, because people, kind of put it as a wastebasket term, but, really there are some good treatments for fibromyalgia now. So I think empowering the patient, recognizing central pain, that you might need different meds to treat these pain, I think is a really important concept, right? People come into your office and they probably want the one drug or the one diet that's really going to change the pain, but in reality, it's probably not that straightforward. And we really need to empower the patient to understand, depending on where your triggers are for pain now, it may be even different, the following year that you come in. And I think all of those are, really important to pick up. The other thing I find really difficult, and I would love, the panel to talk a little bit about it, there's other sort of symptoms like fatigue that I hear a lot that I find really difficult to sometimes overcome and try to understand how that fits in. Because, the exhaustion that goes along with sometimes the pain, sometimes if you don't address those other parts of related pain, it also gets really difficult to get through to make the patient comfortable. So I'd love to hear some techniques. I find fatigue one of the hardest things that, when I hear, I'm like, I'm fatigued too. And like, how do I get you to that next level? Because I feel,
I never thought,
really have to come to some, I know there's a lot of research into it and really come to some terminology around that. But I think the first step is just to acknowledge and, like having this panel, like just talk about it, I think is so important.
Yeah, I definitely find that fatigue is sort of number one. It's a ubiquitous term that everybody who is in my office complains of fatigue. But I think that understanding that it's a very subjective experience, number one, and it could not be more heterogeneous. Elaine, as rheumatologists, you and I became very familiar with the idea that our systemic diseases, if they cause inflammation, can certainly be accompanied by fatigue. Certain medications like methotrexate can also cause fatigue. And then there are innumerable fatiguing illnesses like anemia and thyroid disease and depression that can also contribute to, and fibromyalgia, of course, with fatigue. But, I don't want to get on a tangent, but, yes, for a chronic fatigue syndrome type of fatigue, it's a very different experience. It's really an exertional intolerance. Patients with CFS simply don't have, the energy production that meets the demand, the metabolic demand. And so the experience and the symptom is very much different. It's a overexertion and then I crash a few hours later, or I'm in bed for a couple of days. And it's very different than the pain that we see in fibromyalgia, which is a little bit more consistent, doesn't really have significant crashes, but they all can be associated with non-restorative sleep and cognitive fogginess and everything. And so as we know, these pain amplification syndromes also piggyback. So you start to get a history of maybe irritable bowel or interstitial cystitis and migraine and things like that. And then you kind of know that you're in that, pain amplification or central sensitization territory and not just, straightforward RA or a straightforward osteoarthritis. So let's talk about, if we can, I want to talk before we have to move on to a different topic, some of the big things. So are opioids still a bad word? Are we still able to use them in any capacity to treat pain? And maybe Rinelda, you could speak to that a little bit about, let's say, post-op pain and how do we prevent post-op, narcotics from becoming lifelong narcotic use. And maybe Natalie, you could talk a little bit about that. And I'd like to get in CBD a little bit before we move on to some other topics. So Rinelda, Can you give us your impressions and opinions on opioids?
Yeah, so I think definitely we're all under the watchful eye of decreasing the use of opioids. And so we're all using less now. And I actually think the patients are doing better. And as we use a multimodal regimen in terms of controlling the pain. I think at one time we thought it was the particular technique of the surgery that we were doing, smaller incisions, muscle sparing, things like that.
Mm-hmm.
But I actually have come to the conclusion that it's really what we're doing to control their pain. So currently at my institution, we have something called an ERAS protocol, and it's like a accelerated rehab. And basically what we do is patients are actually, they are allowed to drink. We give them something to drink. It's almost like a Gatorade the morning of their surgery, as opposed to being NPO. They have this gum. And so we get them up. They have physical therapy right after the surgery. No longer are they laying down. I think being mobile helps not only just with formation of blood clots, but it just helps the patients in terms of moving. We give them an injection, an intra-articular injection that helps with the pain. We do more regional anesthesia as opposed to general. A lot of the complications I think that patients had after surgery, we may have inflicted them on them because we used the PCA, and then they would have problems with voiding afterwards, and some patients would have nausea with that. And we use an anti-inflammatory, usually the Celebrex or meloxicam. Along with that, we tell them to take Tylenol. At one time we were using IV Tylenol. Now we've gone to like peel Tylenol. It seems to work just as well. We still give them narcotics, but when I first started out, I used to routinely give patients 50 Percocet tablets.
To go home
I
with.
always give my prescriptions before surgery.
I know.
I'd always go, so they're all set up, and I give them 50 then, and then I would write the prescription before I went into the room for their first post-op, because assuming they've run out. Now I give 20, and you would be surprised the number of patients do not need another one.
That's amazing.
And I feel like I'm still doing the surgery pretty much the same way. So I really think it's everything that we're doing up to that, and everyone been on the same page. We're talking about it. And the patients really, for the most part, they don't want to take the narcotics because all of the side effects that they get with it, the constipation, they don't feel well with it. And it makes them jittery after a while, so.
That's wonderful. That's really great to hear. Natalie, what about you? And, do you find that patients are wanting to self-medicate with CBD, let's say? Do you deal with a lot of patients who are narcotic dependent? I'm just curious, your experience.
In my experience, patients are often looking for whatever helps. And sometimes they get into a cycle of looking for things outside of them, including medication or supplements or CBD or whatever the case may be. But what that does is it takes away their own power. It can be disempowering for a patient to believe that the solution to that problem is outside of them. And that's not to say that there aren't helpful solutions and there isn't medication to take, but we can develop an over-reliance on those things and essentially disempower ourselves. And we have the ability to take control of our pain ourselves better. We can better manage our pain ourselves through all sorts of behavioral practices. And so to the extent that you can combine some of those, I think it really helps to send the message, I can do this. I can do this on my own. I'm strong and I'm capable. And to practice those techniques and really teach people how to do that and kind of coach them through it, I think has been really, really helpful and rewarding.
That's great. And one more thing before we go off to the next section, Elaine, how much do you encourage your patients to, participate in physical activity and exercise as a way to moderate their pain?
It's a great question. So I think, most people feel like if they have some type of arthritis, it's going to kind of hurt them if they move, right? So I think that's really what I get. They just don't want to make anything worse. And so the immediate reaction is that I can't move, can't exercise, shouldn't do anything around the house because I'm going to get worse. And it's actually the opposite that's true, as we know. It's sort of, that motto, you move it or lose it, right? So, but there are ways that we do that. It doesn't mean that, everyone has to go out and get a trainer and, join a gym, right? So there are safe ways to get back into your activity. But I don't think there is, very little, I think, evidence to show that no activity is always the best, right? So unless maybe you have a fracture, right, Rinelda, then maybe we'll have to cast you. But aside from that, I can't really think of a scenario where, Natalie and I would say, okay, absolutely no movement. And it's funny because if you think about how we used to treat rheumatoid arthritis, we used to admit them and keep them in the hospital, right?
Right. Bed rest,
that paradigm, and that was the Arthritis Foundation. I remember that paradigm when I was in training. It's like totally flipped. We are now, not relying on that. We're actually trying to get people to move, but move safely, right? So even if you can't do land-based therapy, I'm a big proponent of water-based therapy to start, right? Some people just can't do the land-based therapy right away. There's water-based therapy that we can do to really, there's, not just yoga, but there's chair yoga. And I, tell people, you don't even have to go to an expensive studio. There's so many now online, for chair yoga, at least get some, girl or guy that you don't mind looking at and the music's okay, but don't be afraid to explore, because sometimes there's really annoying people doing yoga and it just turns you off, right? So I tell my patients, you have to really utilize, and don't be afraid. I think a lot of people come to me and say, I have, either you could be a single parent and you have, many kids and there's all these outside influences, but 10 minutes a day, you can do 10 minutes a day, I think, and work your way up. And I think those are important messages because I think people feel, and it's the same with weight loss. A lot of people get frustrated because they feel their ideal body weight is like, losing 40 to 50 pounds. And maybe that's true, but if you just lose, 10 pounds, 8 pounds, you're making a huge difference on your knees and your hips, and I think making those small gains is something that we may not, always, take the time to tell our patients. And I really want to send that message that small gains are still big gains. And, it's really hard, I think, to take that initial momentum. And, I find that we're, really lucky that we have a lot of digital health sort of options nowadays. And I know the Arthritis Foundation has a lot of local community programs that my patients have benefited from. But it's just up to us to kind of push people to believe that you don't have to do that, huge step forward, many, many steps. And I'm like so happy for the next visit.
Right. That's great. Natalie, I wanted to ask you, actually, in your opening comments, I thought to myself, how do we find psychologists like yourself, right? So are there specifically trained therapists who deal with chronic pain, number one? And so are they hard to find? Because I would love to be able to refer my patients to that, to you. And also, can you give us some examples, like sort of, if you have them, some concrete examples of things that you advise patients to do to sort of change their mindset about their pain?
Absolutely. Yes, it's a specialty in psychology. So you can get specialized in treating pain specifically. We have pain psychologists and health psychologists, and you can find them through the American Psychological Association, and they have ways to locate therapists in your community and who are accepting referrals and whatnot. This is such a critical piece of this whole body treatment and the way that we think about pain from a biopsychosocial perspective. When it comes to the psychology of pain, like I said before, how you think about it is going to make a big impact on you experience and how distressing your pain is to you. And we call this catastrophizing. This is the phrase that we use to talk about a process. It's like an appraisal process that often results in paying more attention to your pain, increased perception of threat. So it's like it feels very dangerous to have the pain, and expectations of heightened pain. And all three of those combine to really amplify the pain experiences in ways that we can then change. And so the three components to that are rumination. And rumination is this, I can't stop thinking about it. It's on my mind constantly and I can't get away from it. And the more we think about anything, the stronger it gets, the better the brain gets at thinking about it. So we can actually sort of teach ourselves to experience more pain simply because we're paying so much attention to it, thinking about accommodating it, changing our lives in order to accommodate it. Magnification is this amplified. It's like something bad will happen and the pain feels very scary to me. And when that happens, we're activating fight or flight. We feel very anxious. It's a very frightening experience. And this is going to limit people's activities as well. The other piece is helplessness, that it doesn't seem like anything I do will help. And when we, make multiple attempts to fix problems and it doesn't seem to be working, we can, depression is one of the consequences for that. So you can see how all of these things begin to relate and kind of play off of one another. When we feel bad about our attempts to feel better, and then we just kind of concentrate on it a lot. We think about it a lot. We talk about it a lot. It really becomes all-consuming. And we can teach people how to either direct their attention elsewhere in intentional ways, calm their body through relaxation, response training, and really shift their thinking and their behavior in ways that are going to support living with less pain. So I think that's really important. And the other thing that we know now is that pain is in the brain. And if we can calm the brain, we can calm the pain. And so that's something that we didn't, we never really kind of, we didn't fully understand from a behavioral standpoint so much before, but we know that now. And that's really important because we do have good techniques that you can learn, that you can practice, like at home today, that will help to calm your brain and calm your nervous system and hence calm the pain.
Is there a place where patients can find this, like at the American Psychology Association, like website or something? Because I feel like this would be so helpful for people to start and for me to be able to guide patients before I'm able to find, a therapist, or maybe it would be cost prohibitive to see someone. You never know, right? So
there's actually an app that I recently discovered that was, came across my feed or whatever. And I checked it out and I looked at it and I have there's no, I don't,
You don't gain any money.
I was like, well, is this, would this be any good? It's called Curable. So I don't know if anybody out there has tried it. It's actually fantastic. And it walks through the neuroscience and the,
I love that,
of pain. And it kind of talks about the 6 basic truths of pain. And it's very educational. And one of the things that we know is just having more education and knowledge about pain can be therapeutic.
And insight.
Just understanding better what what's going on for you. And then you're better equipped to make decisions on how to deal with it. So I don't have an endorsement. I don't have any, but I just thought it was really pretty great. Actually.
No, that's helpful.
It's good to know.
That's really good to know.
That really resonates with me. What I find sometimes difficult is to send that message, that messaging. So we all understand the sort of central, amplification, but I find sometimes maybe you're busy in clinic, but it'd be really helpful for, the patients on the call. Sometimes it can be interpreted as, oh, she thinks it's in my head. Like I went there for my pain, for my joints, for my RA, and she, so I do think there is also a level that we as practitioners need to learn how to maybe send that message. Does that make sense? Like,
yes.
Well, absolutely.
And it's not in your head, but it is in your brain.
Right.
I know.
And I think
I always find myself saying that. I'm like,
I'm gonna use that. Yeah. So
I say that to patients, and I say, like, it really is in your head because it's the way your brain is, handling this pain message incorrectly or whatever. So I do, and and I'm sure everybody here can attest, especially as we are all female practitioners, that just listening to the patient alone, right, goes so far. That patients feel heard and their complaints are taken seriously. They're already like that much, they feel so much better already. And we will get into that a little bit, but I wanted to ask, so we talked a little bit about medicine. Of course, we can't go over all of them. We didn't, there's NSAIDs and CBD and opioids and everything, but I'm sure all of us have experienced this, that, well, doc, I don't really want to take any medicine. Is there a supplement that I can take? And so I'm going to throw that a little bit to you, Rinelda, because I'm also interested in your take on stem cells. The way sort of the party line at my institution is that it's not ready for prime time yet, but I'm interested to hear your perspective as an orthopedic surgeon. And then I'd also from the group and Elaine or whoever about nutrition and the role of nutrition in mitigating pain and fatigue. So let's start with supplements, Rinelda. Maybe you can give us your opinion on, hyaluronic acid injections or glucosamine or stem cell, or just how you guys think about it in ortho.
Sure. So in terms of supplements, I do get a lot of patients who either don't want to take an anti-inflammatory or can't. I get that a lot.
Right.
And so I tend to go with, for those patients, maybe something more natural. I talk about diet and foods that maybe they can incorporate. And I use turmeric a lot. I speak to them about that. Certain, I just heard this recently about pineapple. That's a fruit and I just heard that this week, and I was like, really, I'm going to use that. That they use that in terms of its anti-inflammatory tendency. So I think that's something to try. I always talk to patients about whether or not, like if you have gout or something like that, then definitely diet is very important for that. In terms of glucosamine and chondroitin, I tell patients, particularly early on, I said, try it. Usually try it for about 3 months and see if it helps you. It doesn't help everyone. It's about 50-50, which is like flipping a coin, honestly. Some people will swear by it. Other people say it didn't help them. And it's not cheap. And most of the time it's not covered by your insurance company. So try it and see. And then I used to tell them even try the liquid form, see, because people would say the liquid works better than the pills, or they didn't like the huge pills. And I used to go and find it somewhere, like Costco or Sam's, somewhere it's cheap, and you can get it, and try it for 3 months and see if that helps you. In terms of the Hyligan injections, in my experience, and I've tried a lot of them, pretty much everyone they've made, I think, they help early on. And just about everything helps early on, okay? But later on, when it's bone on bone, it really doesn't help. And it's kind of like the steroid injections. They help early on. But as it gets later, they stop helping. But I do think they help longer than the hyaluronic injections. So, and in my practice, we only will give the injections every 4 months. So we don't give them excessively because it can deteriorate the joint. I really talk to them about, when I'm talking to my patients, like the first visit, we go over like the options are. First thing I say is like, you have arthritis and there's no cure for it. So this is what we can do to help with your pain. But it's going to come, you're going to have flare-ups. And then we talk about medication, we talk about the supplements, we talk about exercise. I give every patient some exercises to do. I want them to do exercise, and they're knee arthritis exercises. So these are exercises for people who have arthritis. I tell them that they need to move because it'll get worse. You'll get contractures, weakening of the muscles, and that'll just make it worse. And plus you'll gain weight, which will make the arthritis, worse. So moving is important. And we talk about low impact, certain things, lunges, squats, things like that you probably can't do will aggravate your arthritis, but there's still a lot of things that you can do. And I think just going over it with the patient, and I always tell them, just because I'm a surgeon, it doesn't mean that every patient needs surgery. And a lot of patients are sent to me when I tell them, oh, you don't need surgery, they're so relieved. And I always say I'm a conservative surgeon because I like to try other things first. That's when that fails, then we look towards surgery. First of all, I want them to have that they trust me and they feel like I'm not just coming every patient I'm going to operate on. So I want to build that trust. But I also think that surgery should be reserved when conservative treatment doesn't work any longer. And the thing that I always tell patients that bring patients to me and decide to have surgery, and it's their decision. I always tell them it's their decision. Once I say that you're a candidate, you make the decision. You decide if you want surgery, when you want surgery. I'll just tell you if I think that you're a candidate for the surgery. But in my opinion, it's when they start losing sleep, which gets to what you were talking about earlier about fatigue. I think it's because the pain, and you have a lot of pain at night, musculoskeletal pain, it prevents them from sleeping and resting well. So they're tired. Yeah. And it just goes over through the day. Yeah. So I think that has something to do with it, because it seems like when you're trying to rest, that's when the musculoskeletal pain, it starts. It's just they have a lot of pain at night. And that's what really, in my opinion, brings patients to the side. You know what? I'm ready to have surgery because it's affecting my sleep.
This is very enlightening. I hope it's enlightening for everybody else because that's really important. Can you just, before I move on, I'm curious your opinion on stem cells.
Oh, okay. Oh, yeah. I forgot about that. Sorry about that. So there's a
yeah, we're not going to let you go without that.
Yeah, very small population that's useful for it. And it's really more sports medicine than the arthroplasty surgeons because it's a discrete lesion. Most of the time when I see patients, it's the entire compartment, if not all 3 compartments, and they're not a candidate for it.
Okay.
It's a very small.
Yeah, you're right. It is more sports medicine. You're right.
It's more, and it's a small lesion, and I tell patients this all the time. They're too far gone for that. When they see me, most of the time, it's way too late for that. And it's really when you have a traumatic lesion at this point. Now, I don't know what's in the future, but I don't think it's anywhere. It's a while yet before it's going to replace joint replacement surgery.
Thanks, Rinelda. Okay, Elaine, what do you tell your patients with arthritis to eat?
Yeah, I love that question because I get it every day. I actually have a research interest in nutraceuticals and I study it a lot.
That's awesome.
But even being a big proponent of, looking at active ingredients and looking at study designs for this, I don't think that we should think about it as, what is that right thing to buy, at your grocery store. I look at nutrition and nutrient dense foods as an adjunctive therapy. And I think that's really important just to take a step back, because I think if you're expecting pineapples or whatever your food of choice, if you look at it as something as a sort of a first line or a cure, I think that's going to be a tough path to take. But I think if you look at lifestyle modifications as pillars and adjunct to your health of whatever type of arthritis you have, whether it's a non-inflammatory like osteoarthritis, or, an inflammatory arthritis like, psoriatic arthritis or rheumatoid arthritis. So I do need to, really take a step back and let the audience know these are adjunctive therapies, but it is not, I also do not think it's an option. I think lifestyle is, a primary adjunctive. So what I mean by that is nutrition's important, so is sleep, so is mindfulness, so is exercise. And these lifestyle modifications are something that you can control. Now, not everybody needs to do all those pillars, right? I mean, if you're a good sleeper, you got to move on. It's maybe mindfulness or social connectedness, or maybe it's the nutrition part that you need to, be a part of. But I think the more that we are able to teach patients about these pillars of lifestyle modifications and to address these, little at a time. It's not like one visit, you have to, ask your physician. I mean, many people come in and say, should I be on a gluten-free diet, right? Or, and I think that the way that they even ask the question is very telling, because that's a teachable moment, right? If you're feeling like you're looking for an answer for one food or one diet, that path is really going to be an uphill battle. Really what you want to tell your patients is this is a very important adjunctive therapy. We need to take care of your underlying disease first, or the best that we can, whether we need an orthopedic surgeon referral, whether we need, a pain psychologist as well. First, the underlying disease needs to be treated the best we can. And then we look at these lifestyle adjunctive pillars. And I think we are making huge strides in nutraceuticals and, but I think the very most important thing that people can do, even until the research comes out, is really to focus on nutrient dense foods. There is nothing wrong with, really looking at your diet. If it's something that sits on your shelf, I tell people, and you don't need to refrigerate it, and it's sitting there for 7 days and it looks the same after 7 days, that is like the first thing that it is processed, full of things that are not nutrient dense. Those are empty calories, right? So the more we get used to that, trying to eat things that rot, those are the fresh fruits and vegetables. Those are the things that really should be filling your refrigerator. And I think, these services now that are able to send groceries, I know it's sometimes cost prohibitive, but the concept that you have to go out and get fresh fruits and vegetables are really helpful. The fact that something sits there for 2 weeks and still tastes good, I don't know. That should be the first sign that, the cereal boxes, the cookies,
I feel like we've come such a long way from, I feel like early on in practice when patients would say, oh, when I eat, tomatoes or peppers, and I was like, oh, what are those? Oh, those are nightshades. And I would say, I don't know that I even really believed it, because, oh my gosh, talk about what a deficiency in our medical education. At least when I was in medical school, we did not talk about nutrition. It was just maybe, I mean, at that time, that was the 90s. It was low fat diet is what you had to do. Like it was all about cardiovascular health. It wasn't at all about your musculoskeletal health. Now I actually refer everyone to the Arthritis Foundation website. And I'm not just saying that, it is true, because I love that section of the anti-inflammatory rheumatoid arthritis diet. And although I joke and I say, unless you're, living under a rock, you're all aware that a Mediterranean, mostly plant-based diet, sort of is the right way to go. But sometimes you just need to be reminded of what that is and what that isn't with pictures. So I really do love the way our Arthritis Foundation does that for patients. We talked a lot about, the big joints, as Rinelda, with knees and things like that. But I feel like, so many patients are always complaining of hand pain, right? Mm-hmm. And whether it's rheumatoid or psoriatic or osteoarthritis, or even the pain and stiffness and even swelling that can happen in fibromyalgia, I feel like, and or carpal tunnel, there's so many things. Elaine, what's your kind of go-to for evaluating pain in the hand joints? And do you use cortisone shots there when it's 1 or 2, so you don't have to give them, systemic treatment? Do you use topicals on the hands? I'm just, curious a little bit about your
that's,
take on that.
As we all know, we have to use our hands every day for so many things, just to get dressed in the morning, turn off your alarm clock, So obviously the hand joints and the small joints, as you're alluding to, really hit home, right? Because you're trying to button, you're trying to take care of your kids, and, it's all in your hands. So it's not like something like your shoulder or something where you can just kind of let it, stay still for a while until you have to do some big things. So I agree with you. These small joints tend to, get a lot of airplay, because it's like when your hands hurt, it's like everything you do. So I think, it's really important, like you said, you mentioned, a good evaluation by, your internist, by your rheumatologist, to really understand, why you're having the hand pain first, right? Because if it's, something that's untreated, like an inflammatory arthritis, all the adjunctive therapy you use is not going to get as far as, really, treating the underlying. So I have been, really, I think, lucky working, probably at a bigger institution like you guys as well, where you can have, a lot of your imaging modalities at you, meaning, so if you do the exam and you do the x-ray, simple things, and you just aren't sure why that person is still having pain out of proportion that's affecting their activities of daily living, we do a lot of, musculoskeletal ultrasound. Yeah, we do a lot of MRIs if we need to, so I think we have really changed our, ability to image and to really kind of, look at, some of these things. And if we really don't see anything on that, I think we get a lot more confident about, other treatments. But I kind of prioritize things. So if somebody's really having hand, pain so much that they can't do their activities of daily living, is simple, holding a coffee cup, we look, is it from the nerves? Is it from the joints? Is it from the muscle? And then if I can't figure it out on exam, what I love is that, right, currently now we have all these modalities, some that don't even have radiation, right? I mean, you could do musculoskeletal ultrasound and get so much info on tendonitis and arthritis, so I think from that standpoint, we're really lucky now that we can really hone in on what the underlying factors are, and then we prioritize and treat.
That's a good reminder to use the modalities that we have, right? Okay, so doctor-patient communication, probably one of the biggest issues for our patients in particular, who maybe predominantly are female, who, in addition to their, physical complaints, are unfortunately statistically a little bit likelier to have, depression and pain. So if I could ask all the panelists, what is the most important message that you could give to a patient when they are about to go into either the therapist's office for you, Natalie, or seeing an orthopedic surgeon for the first time or going to see a rheumatologist, what is the most important thing that the patient should really be sort of, equipped with, if you will, when they come to see the doctor? Elaine, you want to start?
Yeah, I think with all the different treatment modalities that we have and all the different adjunctive lifestyle modifications that we talk about, I think it's really important to have shared decision making, in terms of talking about doctor patient. I mean, if you're like my parents, like they go in and I'm like, what did the doctor say? And they're like, well, they told me to do this and that. And that was the end of the conversation. Like they
Right.
weren't included, right? So back then, I think it was very common for physicians and doctors and patients to really have a one-sided almost conversation. But what I'm finding now is, we're really getting better at, I was on the, I think this was a really interesting story, but I was on the psoriatic arthritis guidelines committee, and we had patients there for the first time this year. I think that's wonderful. That sends such a message to me and to the younger physicians that they are like on the voting panel. We have patients suffering with the disease side by side with us, looking at the guidelines that are going to be recommended nationally. So I think that to me really has been a great example of how we've changed in our doctor-patient communication and really, involving the patients in making decisions about their treatment. I think that's really important. And I think it opens the door to really, going where the patients are. And that's have really helped, many times I'm sure, Natalie and I are choosing between all these myriad of DMARDs that we have. So we're so lucky we have this laundry list. But, some are, it's really important to include comorbidities and to educate the patient. That's just a fancy word for associated conditions that are with all the diseases that we treat. And now that's starting to play into how we pick medications and how we pick and prioritize different treatments, whether it's non-pharmacologic or pharmacologic for our patients. So I think that's, really important to kind of put out there.
To think about. Natalie, I'm curious if you have this conversation with your patients about their relationships with their doctors and if they ever, discuss with you or complain to you and say, I just don't think that this doctor is really listening to me. Is it okay for me to find a new doctor? And many patients are very, concerned or reluctant or scared to do that. And, how do you communicate about that with the patients and do you empower them to make these decisions for themselves as they are the keepers of their bodies, of course?
Yeah, I actually do. It's sad and it's a little disappointing how often I have these conversations with patients about how they don't always feel heard. And it's often the case that there isn't a clear, there's not a clear diagnosis. There's not a clear, pathophysiology. There's not a clear treatment path. And so where it's really confusing, it becomes really confusing for the patient. And what happens is I think sometimes everybody gets frustrated. So, the patient's frustrated because there doesn't seem to be a solution. It's not getting better. And then sometimes the provider, the physician can get frustrated too, because, they want to be able to help. And if that's coming up short for whatever reason, I think everybody involved can start to get really frustrated. And when, sometimes patients can begin to feel dismissed. And I think that can be a real problem for like the obvious reasons, but also what happens from the patient is that it feels like you need to really convey just how much pain I'm in. And by doing that, you're sort of self-amplifying the pain by trying to either convince somebody else or even yourself that I'm really in as much pain as I say. And again, if it speaks to the psychology of pain and how we think about pain and how much attention we're paying to the pain and how much we're talking about the pain and how much we're trying to convince somebody perhaps that we're in pain. And that just has this sort of like feedback loop that could actually make the pain worse or your perception of it worse. So I think this, the doctor-patient conversation, that relationship is a really critical part of the treatment. And I think outcomes are really dependent on having relationship, joint decision making, and feeling heard and understood. If that's not happening, then yes, I might consider trying to find a new doctor. That is not always an option, unfortunately. That's not as easy to do as it sounds. But if it is an option and you don't feel like you're getting the treatment or getting the the attention that you need to feel better, then maybe consider a new doctor.
Thank you, Natalie. That was very helpful, really helpful. And Rinelda, I'm curious, you're a woman or a female orthopedic surgeon, so you are still, I'm assuming you're not the majority yet, right? I mean,
No.
I think it's still a very male dominated field. I'm just curious. And we have wonderful male colleagues. We all do. Many of us might have husbands, sons. So nothing disparaging against guys, but do you find, I'm just curious, like if you have, female patients who may have not had such a great experience with, a male orthopedic surgeon, and, how does that resonate with you and your experience?
I definitely think we definitely all have had that. Patients feel that the female physicians will spend more time with them. They'll listen. We tell them the same things in terms of the classic example is weight loss. And I've had patients come to me, well, he said I was fat. Well, I know he didn't say that. I mean, nobody says that. I even went to my partner. He said, I didn't say that. And I know he didn't say that. But it's the way you say it and their perception and everything changes.
Sure,
I know he didn't say that. And I was said, well, you need to lose a little weight. You're heavy. It's the way you say it. And I empathize. I struggle with weight myself. I know how hard it is. We've all gained weight during COVID. So we do a little bit at a time. I try to encourage them to do that. Even if it'll help you, we can see you once a month, a nurse check on your weight, just make you accountable. We do it together. I think it's how it's said many times. And a lot of patients do prefer a woman. They feel like you can relate, you'll understand. Perhaps you've gained weight yourself after having a child, as you get old, it's different. And I just try to talk to patients and that way. And I've had patients, male patients actually, who've told me that I changed their life because he said, it's just the way you said it. And then I got serious about it. He had bariatric surgery. I just operated on someone maybe 3 months ago. He lost, it was a different person when he came back. I think he lost 140 pounds. And I said, oh my God, what did I say differently than everyone else? I'm sure the man said, he said, it's not what you said, it's the way you said it.
You said it, I know.
It's just the way you
I'm
said
sure
it.
we've all, I've certainly, Elaine,
The
you too,
mother,
I've had male
I don't
patients.
know. It's just they can relate to it because I say it more, I guess, more relatable. I understand, but we got to do this. It's making it worse. We can't go any further. We're limiting our options. So, and then they get serious about it.
I know. I'm just thinking though, and I know this is not about us, this is about the viewers, but I often think by the time I get home and then my kids need something, right? And then, so everyone needs something. And I say, gosh, I have caretaker fatigue, right? Because we're taking care of our patients all day and they do have an expectation that we're going to, listen. And that's of course what we enjoy about the job so much is that connection and being able to help people. But I'm just
I just wanted to interject. So it just reminded me, when I was a younger physician, I think I felt like I had a template in my mind. So if you have RA, I'm going to do this, this, and this. And now I realize that what would be really important for the viewers here too is to, maybe help the physician prioritize an agenda, because I can't read your mind. And yes, I have all these things I want to do, just like Rinaldo and Natalie want to do for the patient. But I sometimes I ask permission, I've noticed that, you've gained some weight and that could affect your RA. Would you like to talk about it today? I ask them permission, because if they're not ready to talk about it, I could yap all I want in that appointment about weight loss, and it just won't be the right time. So I found that sometimes helpful, because then I'll go on to something else and maybe readdress that at another point. So I think I've changed my ways over time a little bit where, rather than having my agenda, I'm trying to be more mindful. But as a patient, I think you also have some accountability in that, your agenda, you maybe need to speak up a bit, at that appointment. I really want to address these, and maybe, just the top 3 things today. And sometimes that puts us on the same page, if that makes sense.
And make the list more, easier to attack. When you come in with multiple, it's just too much. So I said, let's focus on 2 things today. you know, because then I can really address it and devote my time, thoroughly examine you and do all the things we need to do it properly, as opposed to multiple things. You can't really address it well in the time frame that you know that you have, because we all have a certain amount of time that we have to see patients, and then there are other patients waiting and they're upset if they're waiting because we're in there too long with another patient. So
I agree.
sometimes we have to get it more focused and say, let's address this so we can do it well, and we'll come back, because I want to see how you're doing anyway. And now with virtual medicine, coming back or following up doesn't necessarily mean coming to the office. It can be an email, it could be a phone appointment, it could be a video appointment. So there's so many options now that we didn't have. I think that's one of the great things about COVID. Actually, it taught us how to practice medicine a different way. Patients don't always have to come back for a follow-up. And I think they like it. I actually think patients love it.
Yeah, they do. They absolutely do. So apparently we're getting a lot of questions about pain, which makes sense since that's the title of our webinar. And pain is definitely ubiquitous, unfortunately, in a lot of arthritis patients. So let me ask Elaine, can you give me, like, what are your, let's say, top, 3 or 4 or 2 or 3, whatever we have time for, pain medicines that you like to use? Do you like using Cymbalta? Do you like using gabapentin or pregabalin? Do you use low dose naltrexone? Or do you just an NSAID person? What is your usual kind of go-to?
Yeah, so there's actually, for me, not one usual go-to, because it really depends on what we're trying to treat. We had talked about opioids before, so I can maybe tackle that. So I do think there's a place for opioids for short-term pain, but as a rheumatologist, I don't think I'm the right person for long-term opioid management. I think that really should be with our pain specialist, or Natalie, or somebody that has more experience in sort of long-term chronic pain. So I do think it's important to kind of look at acute pain versus chronic pain, because treatment algorithms change for that. That's the first thing I think of. So in terms of acute short-term pain, I mean, if you are, post-op and stuff, I could see where, opioids may be helpful. I don't think it should be a long-term, solution. And I think if you are needing long-term, that really needs me to partner with someone. So I'm hoping that the patient understands that a rheumatologist may not be the best person for that kind. We do need to partner with someone like Natalie, if we are falling into the more chronic pain, issue. In terms of the exact, treatments that I like to do, I always try to mix, both non-pharmacologic and pharmacologic. I think it's important to do both. It empowers patients because it gives them something that they can do. I also really like to emphasize that a pill shouldn't always be used as thinking that this is going to end, all my pain in every way. I think that concept, really sets you up for a little bit, of not, able to get your goal. I do think that if you do have central pain, the meds that you mentioned, gabapentin, Cymbalta, Lyrica, I find, very successful if used in the right way, right? If you're trying to do, this pill for all different kinds of pain triggers, it's probably not going to work. But if you have all the other sort of, modalities, well taken care of, I think that, meaning if you are having trouble sleeping and you're having, trouble with depression, if those are addressed, I find that addressing the central pain with some of these meds to be, more successful than just throwing it and hoping it's going to, kind of cast, fairy dust on all those different things. So I think, having that reality check, with the patient that, these drugs can be really used, for the centralized pain, but we need to talk about some of the other things that may be, causing you problems. I also think it's important to see the difference between pain that is really affecting all your daily activities of daily living, right? So that's how Natalie and I think of things in terms of rheumatology, versus pain that's just sort of, worse when I really overexert myself and you have to have a plan. So I do think of them in different ways. If it's really bothering you, you can't even get off the toilet, that's one thing, or pain that's just because I, can't really go out on weekends, but I'm okay during my work week. Okay, well, then we can think about, different ways to manage that.
Rinelda, I'm curious, when you Oh, so most of my patients who have, foot pain, if it's not an immediately obvious inflammatory arthritis or something, I usually refer to orthopedics or to podiatry, because I think the foot is such a, it's a tough one to tackle. And we can't be expert at everything, I always say to my patients, so
Right.
it's like from the ankle down, I'm like, but do you find, Rinelda, that you're dealing with patients who are complaining of knee, but maybe it's referred from the hip, or they're complaining of hip pain, but it's really a radiculopathy from the spine, or the mechanics are off and, the foot problem is really causing the knee pain, that kind of thing? Do you find that to be very challenging, or how do you sort of piece together what's what and what it isn't?
Yeah, because oftentimes patients may come to me for a hip and it's really their back. So I have to do both exams to determine it. And sometimes, they come because of knee pain and it's really their hip.
Mm-hmm.
So I have to examine them. My question always happens, do you have problems putting on your socks and shoes? So if they say yes, and I think, okay, let me look at that hip, and it takes just a minute to examine the hip. You can kind of get an idea for that. So yes, it is all connected, and sometimes it's just referred pain, particularly when you have x-rays that may not show that much, but they're having a lot of pain. Anterior knee pain, you always have to worry about, is this a hip problem? Is it a back? Sometimes with that, so do you have any numbness or tingling with it? So that kind of helps me focus. And you really have to, sometimes, with the history and patients, they're trying to tell you, a lot of things because, it's taken them a long time to get that appointment. They want to tell you everything, but sometimes you have to put it together and just kind of like to put everything together and just kind of get more focused and says, okay, and ask some specific questions so that you can determine, you want to at least have the answer for them. Hopefully, where's my pain coming from? Is this knee pain coming from my back? And so sometimes you have to interject and just ask some key questions and says, okay, well, let me examine you and just see. And to answer your question about what I start with in terms of the medication, if the patient can tolerate it, I always try an anti-inflammatory for a month. And my go-to is meloxicam. I like it because it's less GI side effects. It's once a day, so it has great compliance. I tell them to take it after dinner because most people eat dinner. A lot of other meals they may not, but most people will eat dinner. And I find that I don't get as many calls. And then I also tell them, I give them, and I think this is with surgery, medication thing, you gotta create that expectation. This is not a pain medication. You're not gonna get immediate relief. You usually have to take it for 3, maybe 4 weeks. I want you to take it consistently unless it's bothering you, unless you have a side effect. Whether it's helping you or not, I want you to take it so we can see. Not that you're going to be on medication for the rest of your life. I'm not saying that. I just want to see what is going to help you. And then the next thing for me is an injection. I don't like going straight to an injection first. And I always add some Tylenol to it if you have pain in between. I use a lot of Tylenol arthritis. And I usually tell them to stay under, I always check their labs first before I prescribe anything. And I tell them to stay around 3,000 a day. I just don't go to the max and just see how you do with that and tell them you can use that in between and, try some other things with it. But that's my go-to.
Right. I think what has helped me help patients, and I think helps patients understand why they're in pain, is to actually explain pain to them. And so that they understand that not all pain is created equal. And I describe the different kinds of pain. I say it's obvious if you've had a fracture or you have a cut or you have a swollen joint. Well, that's obvious that you're going to have pain. If you have diabetes and you have nerve injury, it's obvious that you're going to have pain. What's not so obvious is the central sensitization, neuropathic pain. But that's how I usually start the conversation about pain with patients, so that they understand that number one, that there are multiple different drivers of pain, and that pain in a part of your body can actually be driven by more than one process, right? So you can have arthritis in a joint that also has been piggybacked with a neuropathic component. And if you treat one without the other, you're treating them incompletely, right? So you give them meloxicam, but they also have a component of fibromyalgia. it will be an
Yes.
incomplete, pain. And you always do sort of one intervention at a time, right? So one variable at a time, so you can see what's working and what's not. As we talked about before, fatigue is another question that's come up a lot. Fatigue solutions, and I would say I would be able to retire tomorrow if I had a fatigue solution for everyone. But I think with fatigue, just like with pain, you have to really try to do your best to try to figure out what's causing the fatigue, because it is, as I mentioned, probably one of the most heterogeneous complaints or symptoms that can be driven by a whole host of things. So what I always do in terms of solution is figuring out what is causing it. I want to know about the character of the pain. I want the fatigue. I want to know underlying medical conditions. I want to know what medications the patient is taking. One of the biggest questions is how people are sleeping, because if you dig, you don't even have to dig that far. You will probably get a history of either disordered sleep or non-restorative sleep because of pain. I pick up a lot of sleep apnea and restless leg syndrome, which is disturbing sleep, which is going to cause daytime fatigue, cognitive fogginess. And you start to really, the solution to the fatigue is really taking an incredibly detailed history and being very patient with your patient and allowing them to tell you all of the characteristics of their fatigue, and then you can start helping. But I would say that fixing sleep disorders is one of the best things you can do for your patient if you can identify one. And so we enlist the help of the sleep specialists quite frequently for sleep studies. You can do them at home. It will pick up OSA or obstructive sleep apnea, but it won't pick up things like restless leg and stuff like that. So it's not as good as a visit. I always say our sleep study center is in Bellevue Hospital, so you can say that you spent a night in Bellevue if you get a sleep study at NYU. But anyway, and I love using a low dose of gabapentin at night to help restore the quality of sleep and allow patients to get into that deep stage 3 of their non-REM cycles, which if you do sleep studies in patients with chronic pain, you'll see that they stay very much at the surface with a lot of what are called alpha intrusions. So that pain that's firing all day long is also firing in their brain all night, and the gabapentin can really help that. So physical therapy, yeah, that's a great question too. And when to use heat versus cold. I actually wish I had a physical therapist here, because I always tell people this, and I hope I'm right. An acute injury, yes, you can use cold. After an acute injury, whatever makes it feel better. Rinelda, is that what you sort of hear from your therapists?
Pretty much. Initially, always ice and elevation. Early on, like for shoulder, we haven't talked much about shoulder.
Yeah, you're right.
And neck. That's a lot of pain that goes down, radiates down. But that heat, I think, works the best. And I always tell patients, get in a hot shower and do your exercises there. It really makes it feel better. Right. After exercising, maybe ice will help. If you have arthritis and if it's cold, usually heat is going to feel better on it. But sometimes, like with hip bursitis, that varies. I like heat. Some people like ice to kind of freeze it. So I tell them to, try both and see what works the best for you.
All right, so it sounds like my advice is right then. That I tell people whatever makes you feel better is the right thing to do.
Just try certain things, except don't use heat for an acute injury. We both agree on that one.
Right. Do you, Rinelda, do you find that you have physical therapists that you sort of work really well with and have a good relationship with, and they're your sort of referral source, and you like to encourage that?
With our group, because I work for Kaiser, basically everyone, they specialize in, there's certain ones, like we'll have hand therapists, occupational therapists, but then the physical therapists, they do both, but there's certain ones that really treat the patients who have joints. And we go back and forth. They send me messages about my patients. So we have a good rapport. If I can't get a patient in, I'll pick up the phone. Can you get this patient in? So there are definitely ones, definitely. Even when I was in private practice, there's definitely ones you'll have, like everything else, you have a good rapport with, and they'll get your patients in when you need them in. And some people need a lot more therapy than others. Some people don't need it. They're more can do it on their own. So, but some people need that instruction.
What's that, Elaine?
I also think communicating with the therapist is important.
Yes.
Write write a form and then that was it, right? But now I
Right.
think on some difficult patients, it's been really helpful to get them involved. We also use exercise physiologists as well. Those are a little bit different than physical therapists, in larger institutions, and those have been really helpful.
Right.
And are you talking about, because I think we had the same thing where it's like there's patients who want to exercise but don't know how to do it safely. And so these are, so you're not just rehabbing a knee or rehabbing a shoulder, but it's someone to actually, guide someone. And, if they have spinal stenosis, well, how can I do exercises and not hurt my back kind of thing?
Yeah, I think they're a little bit more personalized. Physical therapists really take care of, like Rinelda said, if you have neck pain, you send them for, that diagnosis and that,
Okay.
treat and evaluate for that. Exercise physiologists, at least the ones in our institution, unfortunately, it's not always paid by insurance. So there's a little bit of an out-of-pocket cost compared to physical therapists. But I find that they are able to, kind of see them in a sort of, more weekly fashion and, really focus on overall, health and physical activity goals.
So I'm curious, how long, Rinelda and Elaine, do you recommend that somebody tries a pain medicine or medicine for their arthritis or whatever before telling them to switch to something else?
So
Either
Go
of
ahead.
you.
I'll do it.
Go ahead,
For
Rinelda,
me,
yeah.
I usually try to at least give it for nostril, at least give it a month. I like to try everything a month. Even if I give a patient an injection, give it at least a month. Most people see relief in about a week, but sometimes you don't, it's delayed. And some people actually have an acute flare up from the steroid and actually are worse. So I just try to educate them about that. But let's give it a month. It really, I always tell this to patients, I wish I did have that type of power. I could just lay hands on and just make you better today. We all wish we had that, but we don't. So you have to be patient with to try one thing at a time, which is what you said, Elaine, because you don't know, and just see. We try one thing, and I explain to them, this is our focus. We'll try, least invasive, then we get more invasive as time goes on. But we try it and just see, and we work with this, together. But it also requires you have to have an open mind and say, I've tried that, just, okay, let's try this, and let's see, together what we could do. And it may be that there's nothing else, and it may be just surgery, or it may be that I don't have a surgery that can help you, and I need to send you to, Natalie or one of our pain specialists, so we can't always fix everything. I wish we could, but we can't, and we have to really understand that.
I'm curious, Natalie, if I could, I want to ask you if you ever refer patients, one, for acupuncture, and two, do you ever say to the patient, I think you need medicine?
Yes and yes. Yes and yes. I think, I'm a big fan of alternative or complementary approaches. And I think it's a step towards feeling empowered and taking charge and taking back some control over this. And so I think that can be helpful. I think, again, managing expectations is really important. And so I don't think there's going to be any one thing that's going to work, completely and totally. But I think if it's probably worth a try.
Okay, that's great. So one other question is, do antidepressants help with sleep problems due to pain? And the answer is yes, it does. From the earliest experiences with the older tricyclics like amitriptyline, that was one of our only medicines for fibromyalgia way back in the day, but that definitely helped to induce sleep. And there are some, I think there's a subgroup of fibromyalgia specialists who think that it is first and foremost a sleep disorder, and that if you correct the sleep, everything sort of falls into place after that. And I don't know that that's necessarily if I fall into that camp, but I will say to patients, I'll say, doesn't everyone feel better when they've had a good night's sleep, right? It's like everything is better. You feel like you can take on the world, your mood is better. So the answer is yes. Now there are some antidepressants that are purely enhancing a certain chemical in the brain called serotonin, which is great for depression and anxiety. And certainly if you can mitigate anxiety and depression, you can certainly sleep better and you may have better experience or perception of pain, but they're not necessarily meant to treat pain. But medicines like Cymbalta, which enhance both serotonin as well as a chemical called norepinephrine, can actually really help with depression, anxiety. and pain. And so that's why it's a fan favorite for the rheumatologist. Any non, oh, yes, but I don't know if they all work. But you know, I think that what I think this introduces is the concept of good sleep hygiene. And I feel like anyone who's had trouble sleeping probably already knows this because you can Google this information. But there's a lot of things that you can do to help around sleep, from, you know, not exercising 2 hours before bedtime, to reserving your bedroom only for, you know, sleep and intimacy, and not having it also be your office where all, you know, where there's a whole bunch of commotion. I know a lot of people use lavender. One rule of thumb that I think is really, really good is that if you aren't able to fall asleep, you should read a book, preferably not your device, but at least have it on the non-blue light, and listen to some quiet music. And if you're not, I should say, you do that if you haven't fallen asleep after about 30 minutes. You shouldn't just lie in bed for hours and hours and hours.
One of the very best things that you can do to help for sleep is a sleep routine. Like one of the very best things is just create, kind of like you had when you were a kid, or if you had kids,
or what you do with your
sleep
children.
routine. And you kind of just, it actually sort of primes the brain for sleep. It's like, that's what we're getting ready to do now. We talk about the stages of sleep, but we often don't talk about pre-sleep, which is sort of preparation for sleep and switching gears from like being very active and kind of go, go, go mode to like winding down now. And sometimes people expect that switch to happen more quickly than it does. And so just making sure that you've left enough time to kind of settle yourself, have a routine that sort of tells your brain and sends those messages, this is what we're getting ready to do. And that helps facilitate sleep too.
I like that.
Good idea.
I've learned a lot. First steps for managing flares. Well, I guess the question is which flare, right? I mean, there's many different kinds. First steps for managing flare. My answer would be to try to identify the triggers, and I know that might sound like common sense, but to avoid them. And so for some people, it's dietary indiscretions, right? Like around the holidays, we have a lot of patients who will have flares of their joint pain and arthritis because they're starting to eat, you know, more sugary foods and things like that are pro-inflammatory. So that's one of the first things. And then probably the second thing is, I guess you're going to call your rheumatologist and tell them that you're flaring. Elaine, do you have any tips for how to manage a flare?
I think this is where managing expectations is really important. I think, you know, Natalie had mentioned, you know, you can have that rumination, right? If you get a flare, you're like, oh my gosh, I'm gonna like not go to work. And, you know, you could think that this is gonna last for months. But, you know, I think if you manage expectations and say, okay, this is what RA, if we're talking about RA flares, this is OA, this is what happens with an OA flare. I think talking about that when, you know, when you get a chance in the office really helps them manage that. If they're going to get a flare at home, then they have a plan in action. When you don't have a plan in action, that's when, you know, I think things can catastrophize because you feel like you're not empowered for the flare. And I think that's something that we, as rheumatologists, you know, sometimes with the less and less time we have per appointment, gets a little hard for me, because if they're doing well, I don't, you know, necessarily triggers me to remember, you know, listen, if you have a flare, this is the plan that we do. Of course you can call me, but there's so many things you can do if you think you're getting, you know, if you think you're getting a flare, you know. So we talked about triggers first, you know, knowing what it is, and then to manage, you know, that joint that's flaring, and to feel empowered, you know, that, you know, you can find different ways to, you know, if it's in your feet, if it's in your hands, you know, to do things, let it go a couple days, learn how to take your NSAID so you're comfortable. What's the difference between, you know, Advil, Mobic versus Tylenol, like all those things. The more you educate the patient, then they'll know, you know, what to try at home, you know, before just calling, you know, the doctor right away, and then, you know, waiting, and then that anxious anxiety waiting, oh, they didn't call me back, what should I do, you know. So I think having a plan to manage flares is really important.
You know, one question that came up is tips for dealing with medication side effects after using for a very long time. And so I'm not sure if that's, you know, one person is having a side effect from a medicine and doesn't know if they should continue on it. That's really not okay. I mean, you shouldn't really be having a medication side effect and continue using the medicine in most cases. And I think to me, that raises a little bit of a red flag for a couple of reasons. And number one is this even in rheumatology, I'm sure, but I think in a lot of other fields, or we learned this the hard way, maybe with Fosamax back in the day, that, the doctor keeps renewing the same medicine over and over and over again. Maybe when you may not need it any longer, or is there, I think a question to that patients should understand that they can ask, like, is there a consequence on my liver or on my kidneys or on my immune system of, just sort of open-ended use of my medications? And, side effects, again, that's all very, very subjective. If your methotrexate's working really well for you, and you're sure that there's no liver toxicity because your doctor's been doing fibroscans and your liver function tests are okay, but you're tired, if you can tolerate it, I think, most people would probably say that that's an acceptable side effect. But if it's something else, if it's, your white blood cell count is very, very low, or your liver numbers are creeping up, or you're having cognitive side effects, or something's affecting your libido, or something, where it's something that could be more impactful, either physically or with your mental well-being, I don't think that that's something that should go unaddressed with your doctor. Does anyone have any other thoughts on that idea?
I wonder if by the question, if they meant potential side effects, like some of the medication, like non-steroidals, the effect that it could have on your kidney and your liver. So for me, I'll refill it, but patients have to get lab work done for me. And for me, it's every 6 to 12 months, definitely 12 months, a hard stop. I won't refill it. I have to check that to make sure it's okay. And if everything is okay, I'll refill it, but they never get more than a year. So it's a hard stop in terms of getting the refills, because some medications, they may have potential side effects, but you may not have that side effect, but other people aren't able to tolerate it. So, but again, I agree with you. If they're experiencing the side effect, then they should not be taking that medicine.
Yeah, I think there's just a wide spectrum, of side effects. And if it's just annoying side effects, as we had mentioned, being tired, maybe we should start taking the methotrexate at nighttime, I tell people, so that you're sleeping through that side effect and see if it gets better during the day. When there's sort of a, less, serious, you can play with, maybe you should lower the dose a little bit and see how you do with the tiredness or the hair loss or, side effects that you see. But if it's something more serious, like you're seeing, black stools or something, obviously you would have to stop the medication. So I think, managing those expectations that there are minor annoying side effects, and then there are serious side effects where, you need to call us right away.
All right, last question. We're going to ask each of you guys what you want patients to know to help them better manage their pain. So Natalie, we'll start with you, and I'm going to go to the left of my screen, which will be Rinelda, and then Elaine.
Okay, so this might actually be counterintuitive for people, but I think it's important to understand that your pain is designed to protect you. That was its original intent, was to inform you that there's an injury or there's an impact on the body that needs to be protected and healed. And so it's actually, when you think about pain as in that way, it's not, you don't feel so victimized by it. And I think sometimes we can get into this relationship with pain in which it feels very one directional. And I think examining the relationship that you have with pain would be an interesting thing to consider. And it doesn't have to be one directional. You don't have to feel like the victim to it. You don't have to feel like you don't have a say in it. But really think about how much control it has over your life. And if you're not okay with that, then know that there are things that you can do to take back some of that control.
Love it. Rinelda, what do you want your patients to know to help them better manage their pain?
Basically that it's unlikely that we're going to get rid of, particularly with arthritic pain, we're going to get rid of all of your pain. And particularly after surgery, there's always going to be some pain. And so we want to be able to make your pain better so that it's something you can live with. And over time, hopefully it'll improve, but there'll be moments when it's worse. A lot of time it's related to the weather, activity level, some other things that may have happened. I always believe in taking something or doing something, whether it be a topical or taking some Tylenol, right away when you have the flare-ups, or, even some over-the-counter NSAIDs before it gets so bad. I think that's beneficial, and just maybe resting it. That may be a time where you want to like rest it when you have a flare up, because we all know of patients who went to bed fine, woke up the next morning, their knee or joints are so swollen they weren't able to get out of the bed. They didn't do anything. They had a flare up. So those need to be, start treatment and knowing what to do, because all the time you can't get into the doctor that day or the next day. So if you know what to do in a situation like that and have medication, because usually for me, I tell patients initially for a flare, take it consistently for about a month, and then you take it as needed. You figure out what you need to do. Start going from every day to doing every other day. You're like, okay, I'm still doing pretty good. Let's go every third day, and just taper it down until you figure out, do I still feel pretty good? What dose do I need? So you're not taking it every day. Hopefully you're not having to do that, but you figure out what it takes. And so really take control, as Natalie said, take control of your pain. You know your body better than anyone else, and just try to figure out what you need to do to mitigate that pain and to help you when you do have these flare-ups.
Elaine,
So
what would you like patients to know to help them better manage their pain?
So I think this is a great question. I would take this example of this panelist that we're on, that it's teamwork. So I think with pain, I think the more that patients understand that it's a team approach, I think you're really going to get ahead of your pain, a lot faster. I think many times you go to one doctor's office and you want, them to take care of, all of your pain. And I think that sets up, a hard expectation. But I think if you're willing to, really look at teamwork, and this panel today, what I've learned is that, there's so many advantages of, sort of using a physical therapist, of using a pain psychologist, of, talking to your other doctors that are also managing, your other symptoms and your other diagnoses, is really the best way. I think to go in and think that only the rheumatologist or the orthopedic surgeon is going to take care of all your pain, or, might be tough. So hopefully that's what came across today, and why, the Arthritis Foundation had a panel.
Yeah.
I think that really helps exemplify, how to get to the bottom of the pain and have you manage it as best you can.
Well, thank you guys all so much. I really hope that everybody learned something. I know I did from all of you. It was such a treat to actually hear from people who are non-rheumatologists, and also so wonderful to hear Elaine's take on everything. Nice to see the things we do the same. Nice to get some little pearls from her too. And I don't know if Michelle is still going to speak, but I want to just plug again the COVID webinar next week. I can't imagine how informative that is going to be. I know we've all been scrambling to give our patients the best guidance. And so, we did get some recommendations from the ACR that we've been able to pass on to our patients, but it's such an important conversation and topic on everyone's mind right now. So I think that's probably it. Yep. And you can register at arthritis.org/webinars, and that is going to be March 9th. So thank you all again for joining in, and I hope you all got something out of it. And it was great to meet all you lovely women as well.
Thank you for
inviting. Oh, I know. Ditto. Rinaldo,
Thank you.
Natalie. Awesome. Thank you.